All right, Carol, maybe you want to get ready to kick us off, love. To Meet the Midwives.
Okay. Hi, everybody. Welcome to our Meet the Midwives, our summer edition of Meet the Midwives. We're so happy you could join us. So I just want to give a quick little intro here. The program is going to be about 60 minutes tonight. We're going to see a short video. We're going to introduce ourselves. And we're going to answer your questions that you are welcome to put in the Q&A, not the chat. Please put any questions that you want answered in the Q&A so we can get to it. Okay, I think without further ado, we're going to get started.
Midwifery?
Midwifery.
Is that right? Midwifery?
I don't know.
Midwifery.
Midwifery, yes.
Is that like a female in her 30s, like, I don't know, married woman?
I know they help during the birth of a child, but that's pretty much all that I know about it.
A midwife can also, as I know, like provide some pain relief in terms of like breathing exercises and things like that.
I think midwives work at a hospital.
Some are in hospitals, some are at home.
I don't think they work in a hospital.
Midwives are everywhere. We're in the home, offices, giving prenatal care, giving family planning care. We work in hospitals, we work in birth centers.
Most people, when you think of a midwife, you just think of somebody who helps women have babies. But we do a lot more than that. We work with women throughout their life cycle.
When someone comes to see a midwife, they often wonder about what we can do for them as far as pain management, as far as medications. They're worried that if you're with a midwife, you can't have an epidural, for example, which is not true. I think a lot of people are surprised to hear the level of training and education that is required to be a midwife in the U.S. because midwives do so much more than just birth.
We provide personalized care.
The main reason I chose a midwife is because I wasn't a number. I was actually a patient, I was actually a person with feelings, and they were gonna devote the time that I needed to answer all of my questions, address my concerns. They want you to make, good choices for you and your unborn baby. I'm so glad that I chose a midwife. It's definitely an ongoing relationship.
Midwives have reduced the cesarean section rate in this country. It's overall been drifting up in the range of 30%. The midwife practice here at GW has a cesarean section delivery rate of 5%. Physicians plus midwives is a way of putting together the collaboration that responds to what the patients want. Doctors should advocate for the midwives. I enjoy the sharing, I enjoy the collaboration.
I chose a midwife because they are trained to deal with birth as a normal process, not a medical emergency. I plan to use a midwife for the rest of my life for my healthcare needs. I trust them and know that they have my best interests in mind, and that's really important to me.
As midwives, our philosophy of care is based on respect for women.
We put the woman and her family at the center of the care and then build out from that.
We collaborate together. We're partners.
I think all women deserve a midwife.
Every woman deserves high quality, evidence-based, personalized care, and we're here to make it happen.
Great. So we're gonna start by introducing ourselves here to all of you, and the first person you're gonna hear from is Jill Sandine.
Hi, I'm Jill, and I'm happen to be on call right now at the hospital, so you're kind of seeing our inner sanctum here. And I am no longer in the office at all. I just am at the hospital for my clinical time. I think Carol wanted us to tell a story about a birth that we had as our fun fact. And this was many years ago. A couple came in. This is when I lived in Minnesota, and they had just moved to the area and didn't have family or friends. And they brought their little 8-year-old son in and didn't have any place to put him. And he hadn't been prepared or anything like that. But he was very curious and interested. And the father kept putting his body in the way so that the little boy couldn't see anything, but he kept peering around and was so delighted by the whole process. It was really a joyful experience for everyone. So that's my little fun fact.
Great, thanks so much, Jill. Linda Rice, could you introduce yourself? Where are you?
Hi, I'm here. I'm Linda Rice. I see patients at the Wellesley office and call at Newton Wellesley. My fun birth fact is, God, there's so many throughout the years, but I think a recent one, it wasn't the birth itself, but the birth partner, as we were pushing, said, "It's so calm. I never expected this. It's so quiet. It's so calm," you know, and you see all the TV and movie, it's everyone screaming and running all over the place and everything. And that was like one of the favorite things I've heard in the last few years, is that's exactly how it should be, just calm and happy. So one other function I do at our practice is help coordinate our midwifery students. You saw in the video the phrase, "Every woman deserves a midwife," and we really believe that. And part of how we try to accomplish that is to try to train the next generation of midwives. So we frequently have students in our practice. To be a midwife, to go to midwifery school, you already have to be an RN. Most of our midwife students already have experience in labor and delivery or some kind of women's health. So having a student with you can be a really nice experience, a way of getting more support, and having an extra birth support person in. And it's so wonderful because, as I tried to say, over the years, even though I remember so many births, I certainly don't remember all of them after 25 years. But if you're, one of your students' births, she'll remember you for the rest of her life during that early stage. So it's really special. So I'd like to introduce the student we have with us now, who is Nikki Del Vecchio, and I'll let you talk, Nikki.
Hi, everyone. I'm Nikki. That is so true, Linda. I feel like in the experiences I've had, I feel like everyone is special because I truly remember every single one that I've been a part of. I have been at L&D nurse for 7 years. This role is so different and wonderful. And I have 3 children of my own, and even that has been a very different experience, being on this side of things, being with this wonderful group, growing into this person, and just being able to be part of this journey with all of you. I'm so grateful that I've been part of this and on this other side, and I can't wait to be a midwife. So thank you for letting me be a part of any of your care. I hope to meet all of you through your labor journey and postpartum, and I can't wait.
Thank you so much, Nikki. Gaitan.
Hi, I'm Gaitan Belacy. I work out of the Norwood and Chestnut Hill office, the West Roxbury. And my fun fact, birth fact, is one of my most memorable births that I probably won't ever forget is a patient that I had. She was delivering her 3rd baby and she laughed the baby out. She was laughing so hard, I had to be like, "Stop laughing," so I could put on some gloves. Because with each laugh, the baby was just coming out. And so the baby just kind of, came with laughter, and it was very beautiful. So that's my fun birth fact.
That's awesome. Caitlin.
Hi, everyone. I'm Caitlin Mayhew. My pronouns are she, her, and hers, and I practice out of the West Roxbury office. When I was thinking of a birth, I guess I wasn't really thinking of a fun fact, but it was a really recent birth, happened about 1 week ago. And it was just really special and memorable. It was a woman and her husband had come in, and she had been undecided on if she had wanted an epidural or not. And so we were really, she came in at 6 centimeters, and she was just, talking very calm, progressed really quickly. And just, I think, we could tell it's just so beautiful when you can kind of see that transition in an individual's behavior, things transitioning in the labor too. And she had a beautiful baby boy delivered in hands and knees, and the whole room was dark, and it was just the baby being born really beautifully. I think she pushed twice, and she was just really surprised at how fast things went. It was her second baby, but it just kind of is really a special moment when you get to be there with someone, from admitting them to the hospital and kind of walking them through what to expect. And sometimes things can happen really quickly, but being able to be there for the birth as well, and just helping her feel calm in that moment too, was really special for me. So yeah, that's my birth story.
Great. Thanks, Caitlin. Mary Kay, our fearless leader.
Hi, everyone. I'm Mary Gosney. I practice at Norwood and the hospital. And when I think of some of my favorite births, because I've also been around a little bit, and I'm not a woman in my 30s, as that sweet guy said on the video. I think what strikes me the most is when I'm with a parent and a couple and a family, and they're working hard, and they're really, just so connected. And after you hand a mother her baby, she looks at you and she said, "I did it." And that moment of empowerment and connection with the baby and with the parents is something I never get tired of. I'm just talking about it like I get chills. It's amazing. And, we have the honor and the privilege to be with you when you experience the hard ones, the easy ones, the births that, you have to go back to the cesarean birth room, the births that you have vaginally. We're there for you in all these special moments. So for me, that's my fun fact, and just the power of women and their bodies and having babies. So
it's true. Molly Doyle.
Sorry, I've got little ones calling my name. So I'm Molly Doyle, and I'm out of the West Roxbury location. One of my favorite births, well, they're all special and magical and wonderful. But one of my most memorable ones was a baby that I caught on St. Patrick's Day, and this baby had pooped inside, so it was meconium stains. Baby came out green on St. Patrick's Day, and the little baby Hulk. So that was a pretty memorable one for me, having a green baby on St. Patrick's Day.
Oh my goodness. Denise.
Hi, I'm Denise Farrell Sanseverino, and I work out of the Kenmore office, and I do deliveries at Newton Wellesley Hospital. My pronouns are she, her, and hers. I just had a really a good birth story to share. When I was on call the other night, I got a call from a patient. Usually they go to like our central triage, and then they page us to call the patient back. The patient was contracting. I called her back, and immediately the patient said to me, I gave her my name. She goes, "I recognize your voice. You were with me with my first baby." And she was in active labor. And I told her, yes, you should proceed to the hospital now. So just by luck, she had natural childbirth the first time. I was with the patient and her husband and her mother, and they all remembered me. And there I was, lucky enough to be on to help her with her second labor of her beautiful second baby. A lot of people sometimes think they only see in the midwife in the office and they're connected to the midwife in the office, and they feel like they want the midwife in the office to be with them for the delivery. But there's a big connection that happens even when you're meeting that midwife at that point in your labor and in your life, that you just don't forget that. So I felt very privileged to be present. 9 years difference between the two births in an entirely different hospital. And there I was assisting this woman with her second baby. I feel so privileged.
You must have been meant to be there, Denise.
Yeah, I guess that.
All right, Kate, where's Kate?
Hi, I'm Kate Murphy. I work in our Norwood office and also at the hospital. My fun birth story is also holiday based, kind of like Molly. I was a couple years ago, and it was a really lovely couple, and they were having their second baby, and it was the dad's birthday, and he sort of we had been together the whole time. It was really nice, just really lovely. And he shared that it was his birthday, and I hadn't said anything because I never want to make people feel bad, but it was also my birthday. And then we had a big birthday party for all of us. So that was actually really a fun birth, actually. But that's that.
That was great. Good for you. Erica, where's Erica?
Hi, my name's Erica. My pronouns are she, her. I am in the Dedham office on Wednesdays and then the Wellesley office on Fridays. And a fun birth that I actually was reminded of this weekend has to do with music. So I'm a really big music person. I love indie and folk music especially, and I go to a lot of concerts and festivals. And so I went to see Brandi Carlile on Sunday at Levitate. Don't know if anyone else was there, but she is an absolute goddess. She's incredible. And so it made me think of this patient whom, she was my patient in the office. And I happened to be on call the day she went into labor, which, is like the dream, like someone else was saying, even though you make fast friends with other midwives. But it was amazing because by that point, her and I felt like old friends. And she also was really big into music and also really big into Brandi Carlile. And I have this really vivid memory of her laboring in the tub before she got the epidural. And we were listening to Brandi Carlile for hours. And I was just sitting on the floor in the bathroom. She was in the tub and we were singing Brandi Carlile together. And it was just such a beautiful moment. And it's one that I will never forget.
That's excellent. That's excellent. I'm Carol Hong. I work from the Wellesley office. My pronouns are she, her, and hers. And I'm also help women in labor at Newton Wellesley. My birth story is also a holiday story. In 1999, I was working on Christmas Eve. It was overnight Christmas Eve into Christmas. And I was staying at the birth center that I was working at the time because there was some weather out there and I was afraid I wouldn't make it. So I'm laying on the couch of the birth center trying to fall asleep, and I get a phone call from a patient who's called Mary. And I said, oh, come on in. It sounds like you're in labor. She comes in the door, and by this time it's actually proper Christmas, December 25th. And her name was Mary and her partner's name was Joseph. And it was Christmas. And I thought, oh my goodness, they did not name their baby Jesus. But, it was sort of a fun, really fun birth, and I'll never forget it. So let's see. Is Megan here? Oh, she is. Hi, Megan.
Hi.
Your turn.
I'm Megan Zisk, pronoun she, her. I work out of the Wellesley office. And my memorable birth recently, so whenever somebody comes in after having a cesarean birth and they're trying to have a vaginal birth, it's always brings up a lot of emotions. And so I had a patient recently who really wanted to have vaginal birth after cesarean, and I was with her all night, and she really wasn't going into labor and not very uncomfortable at all. And then all of a sudden they called me to the room, and she was very, very uncomfortable and having a baby. And so it was just a really just validating, beautiful birth, and very unexpected the way that it went for her, but it was really just a beautiful birth. So that's my most memorable recent birth.
Great, thank you so much. So we're going to get started with the top 4 most frequently asked questions, and Jill Sandeen's going to answer the first one, and it is, what is the difference between a midwife and a doctor, both prenatally and while somebody's in labor?
So I'd like to start this answer with kind of how we're the same, because I think sometimes people don't understand that we do a lot of the same things. So a nurse midwife, both in the hospital and in the office, can provide complete prenatal care, admit you to the hospital, order whatever you need in the hospital, catch your baby, do any kind of repairs. Okay, it's all the same. We can provide birth control counseling and infection checks and all that sort of stuff. So that's how we're the same. How we're different kind of originates in our training. Physicians are trained in medical school. And as we all know, most of medical school is about sickness and pathology. So the perspective of a physician is from that starting point, that they are trying to fix or cure something that's wrong with somebody. And so as a result, they tend to, they're wonderful, our consultants are wonderful, but they tend to focus on abnormal conditions in pregnancy. They spend a lot of time learning how to do surgery, which is a good thing, because if somebody's going to cut into you, you want them to know what they're doing. We, on the other hand, have a different perspective, that pregnancy, labor, and birth are normal, healthy life events. And really, our role is to be your partner in helping the process of pregnancy, labor, and birth and postpartum be as positive and enriching for you as possible. Now, we are admittedly not magicians. We can't make the labor go a certain way, prescribed by everything going very smoothly. But what we can do is incorporate your whole self, your whole relationship, your personality, your hopes and dreams, and value that in the whole process of your pregnancy and labor and birth. And we can midwife you through some of the bumps along the way when things don't go exactly the way you had hoped, and certainly the way we hope. We can help you through that process and still allow the story to unfold in the most positive, empowering way possible. So we want this to be positive. We don't expect it to be perfect, but it can still be something that will be enriching for you for the rest of your life. So I would say that's the main difference. Physicians see patients as more a medical process, and we champion that this is not just a medical process, but a life event.
Great answer. Thank you so much, Jill. The next question that we have, the next most frequently asked question that we have is going to be for Linda, and it is, what is the collaborative care model between the midwives and the OBs? And if I can just make a quick reminder, please put your questions in the Q&A for us to answer. Okay, go ahead, Linda.
So the first thing to note is that we do collaborate very well, that we appreciate our physicians and they appreciate us. And our whole goal is for each of us to do what we do best, to give you the best care and the care that you feel comfortable with, and to honor your wishes as best we can. It starts usually prenatally. Most of our patients are assigned a team of a midwife and a doctor, and kind of who you see when is up to you. Some of our patients say, I would like to just meet the doctor once just in case I need a doctor. We have some patients that say, no, I only want to see midwives. I'm low risk and I'm comfortable only seeing midwives, and that's fine. But most of our patients are assigned a team prenatally. People who choose a midwife to be with them for their birth, we're always collaborating with our physicians. We always work as a team. Most of the time, that collaboration is going to be invisible to you. So we give a formal report once a day with our Atrius team members. And we also, even through our greater team at Newton Wellesley, they do twice a day kind of rounds and with the pediatricians and everybody. So we all know what's going on the floor in case we're needed to help out. If your labor is going fantastic, probably throughout the day, we're talking to our physician colleagues and this is what's going on. And just so we know, even for someone who is completely low risk, sometimes you'll meet our colleagues just because, oddly enough, sometimes babies want to come at the same time, or if someone just needs a quick check or something. If, you know, sometimes we are tied up, and so we often help the physicians and they often help us. If there are complications, or maybe not even complications, but things are moving a little slow, someone's blood pressure is going up a little bit, and it's not quite to that point, we're still usually involving our physicians. Sometimes we'll bring them in to meet you to say, you know, so it's not like last minute, we're not going to wait till things get, you know, get really severe, just to say, this is the physician I'm working with, and now you know them, and they'll say hi. There are some patients that are high risk and still really want midwifery care that we, they're called team patients. So both of us are taking care of you. So the midwives are helping you through your labor, and the doctors are maybe managing your hypertension medicine or your insulin if you're diabetic, or for people like that. And then there are some times during labor when things happen that we say you would really be best served by primarily be taking care of our physician colleagues. Most of the time that means if you need a C-section, but sometimes if you're having severe high blood pressures or other things are going on where we need their help. You know, even though we're formally transferring care to you, it's generally not, okay, bye, have a good life. We try to really, if we can, we'll go into the OR with you. If you're going to have a C-section, if the labor floor is really busy. So if they're doing a C-section for us, oftentimes we may be happy, you know, then have to cover their patients. So, but we'll still see you afterwards and see your beautiful baby. And so there's not kind of a simple answer to that, except that even if you never see a physician, we're working as a team for you. And there's always help available if we need help.
Great, thanks so much, Linda. Gaitan, could you answer the next question, which is who is going to be present at my birth?
So if you choose midwifery care, the person, whichever midwife from our group will be present at the birth. It might be someone you've seen before, or it might be someone here tonight. And then your partner, and then you can have an additional support person after that, whether it be your mother, your best friend, your sister, a doula, whatever you decide. But three people really, the midwife and your partner and an external partner. So 2 support people that you personally know. And yeah, and then if we need to call in our physician colleague and to assess something, then we'll call them in. But mostly you won't see a doc in the delivery room unless we're concerned about you or the baby. So if you choose midwifery care, then you'll see a midwife the whole time if all goes well.
Great, thank you so much. If possible, Mary Kay is going to talk with us about our practice statistics. Oh, Caitlin, I'm so sorry. Forgive me, Caitlin Mayhew. Would you mind answering the next question, which is, what are some of the ways that my midwife can help me cope with the pain of labor, or the sensations in labor?
Sure. So this is a great question. I think someone, or the video answered part of this already. If you choose a midwife, you still have the full access to all pain management options, including an epidural. So the first option that I like to talk to people about is the hydrotherapy, which is the shower or the bath. And I always tell people that it's not just soothing and relaxing, but it also has been shown to be a really good pain control mechanism when the shower is like the warm water is kind of being applied over your belly during active labor. So that is a really good option to not dismiss if you're someone who wants to either wait and see how things go before you're getting an epidural, or if you'd like to go unmedicated. It's just one of the tools in our toolbox. Newton Wellesley also has access to nitrous oxide. So this is like the laughing gas. And as we say, it kind of takes the edge off of the pain of contraction. So it doesn't completely eliminate pain, but it does help a lot of people cope with the pain of active labor contractions a little bit more. There's also different hands-on mechanisms if you're comfortable with that, like counter pressure or things that the midwife or your partner can help you do, just as far as like touch and massage and heat packs and cool cloths that just provide comfort for you throughout your labor. I'm seeing a lot of people coming in with those mini fans that attach to the bed that are really great. And then of course there's the epidural, which is a great way to control the contraction pain. Oftentimes people worry that they're stuck in the bed with the epidural and will this stall labor. As midwives, we're really skilled in position changes, even with epidurals. So position changes and moving around is also a great way to cope with pain in labor. So we have lots of suggestions, whether that's on a birth ball or doing a side lying release, spinning babies exercise in the bed, or using what we call a peanut ball to help open your pelvis in different ways. There's lots of ways that you can still encourage your baby to come down in your pelvis and cope with pain and discomfort by position change as well. So I hope that that answers the question.
I think that's a complete answer. Thank you so much, Caitlin. Mary Kay is going to talk with us about our practice statistics.
Thanks, Carol. Sherry's going to show our slide. So every month we calculate how many births, and we do certain statistics, and then we report them to the American College of Nurse Midwifery every year. It's called benchmark statistics for all the practices in the United States. So we do participate in that yearly. In 2022, we had 678 total births with the midwives. And that usually, we look at the physician deliveries and the midwifery deliveries, and the midwives usually, in 2022, we delivered 54% of all the uterus births. Our epidural rate is about 77%. And we have patients that, come in and your birth intention is to maybe be open to medicate, be open and to see how things go. But these are the women in the end that have decided that the epidural was their pain relief of choice for their labor and birth. Our induction rate is about 25%. And actually, when we talk about our induction rate, we do separate it out. We've got maybe about a 10% rate of post-date inductions. Most of the inductions that we're doing is for medical reasons. If you're 40 years old, it's recommended that the guidelines are that we, have a baby by the time your due date is here. And so, when you see that induction rate, please don't be alarmed. I always like to say that to patients, and we'll have that conversation with you individually at the office. Our episiotomy rate is 2%. And remember, the episiotomy is the cut on the perineum between the vagina and the rectum. Sometimes we need to have a little bit of an opening for the baby. And when we look at everything, when you look at all these wonderful midwives here, we have approximately 226 years of combined midwifery experience. And each year, as our practice grows, that number has gone up. So I think that's really quite amazing. Our primary cesarean birth rate in 2022 for our midwifery patients were 12%. And if you compare that to the last number that we have for the national primary cesarean birth rate was about 22.4%. So we're doing pretty well there. And our feedback rate, I see that there was an earlier question in the Q&A about VBAC, and we had an 85% successful VBAC rate in 2022, which kind of comes out to about 8.5 patients out of 10 will have a successful VBAC with our midwifery practice. And we look at the national rate in 2021, the VBAC rate was 14.2%. So you're quite likely to have a successful VBAC if you come to the Atrius Midwives, because we do pretty well. And I always like to just talk about that because patients always want to know, and we often have patients transferring into the practice to have VBACs with us. So that's our stats. Keep going, guys. You're doing great.
Thanks so much, Mary Kay. The next question is going to be for Molly. And the question is, for those of us who hire a doula, how do we collaborate and work with the doula during my labor and our birth?
Yeah, that's a great question. So as midwives, we are big fans of the team mentality as well too. And who do you want on your team? So that involves a doula. We are so for it. I think it's important to recognize that doulas are there for you and to advocate for you. And they're so devoted to your needs and specialize in pain management and coping techniques as well as the midwives. But on busier nights, I wear my roller skates and I'll be in between 3 or 4 rooms at a time, and your doula is with you the whole time. So when I can't be there, the nurse has to step out for a minute, your doula is there. Doulas are not medical professionals, but they are an integral part of supporting you and your partner through the labor process. So there's a lot of conversations happening or not. You know, we're really good at reading the rooms, and a good doula is as well too. We can kind of work in harmony together with knowing that if someone needs, you know, we said they need to take a break, and we can provide like massage or just more like hand and labor support, or if we're doing an exam, which we don't do a ton of cervical checks, but if we do, and we can kind of figure out maybe positioned a certain way, and then working with your doula to be like, what's going to be the best position to optimize your labor progress at this time. And so doulas are experts in those things as well. So working together to really support however your labor unfolds, and just really collaborating together to give you support that you need. So we are very pro doula. So we're the nurses at Newton Wellesley. They're used to them a lot. And we've got some that, you know, we just work with routinely, but we're always open to meeting new people. So whoever you want is there, but we can definitely work together to help you achieve your birth desires and goals, and a positive experience, like someone else said before too. Not perfect, but positive.
Thank you so much, Molly. Denise, if you could talk a little bit about what role the nurse plays in conjunction with the midwife, and how much of the care during the labor is a nurse versus a midwife.
Yes, usually when you come in labor, and often frequently you're seen in the triage area first, you'll often will meet one nurse over in the triage area. And then when it's decided that you're moved over to the labor area and you're in active labor, you will be assigned one nurse that's usually with you for the majority of your labor. You always have one nurse, and you always have a midwife, because the midwife sometimes, if it's busy, may have a couple of patients and they may have to go between the 2 rooms. But the nurse is usually, they do an excellent job, I would say, at Newton Wellesley with assigning the nurse to be with you when you're in active labor. And so again, she's part of the team, just like the midwife's part of the team, and also our physician colleague that you may not see unless needed is still also part of the team, that we're frequently discussing things behind the scene as well. The nurse is there to help you, support you. All the nurses usually have taken spinning baby courses and are versed in the spinning baby positions. And if people come in with a birth plan, that birth plan is also shared with the nurse, and everybody's there to support the type of birth that you want. If your goal was to have an unmedicated birth, then everybody's there to try to support you and help you in that goal. If your goal was to, when I ask for an epidural, I want everybody to listen to me, and I want an epidural, everybody again is on board with that plan as well. But everybody works together for the type of birth that you would like and desire. We all work as a a team, very close-knit team together.
Me too. Thanks so much, Denise. Megan, the next question is for you. And this question is, can someone have an early discharge from Newton Wellesley Hospital? And how do I know if an early discharge is right for me, or should I just stay?
Sure. So we generally encourage you to stay about 24 hours after your birth if you've had a vaginal birth. And then if you and the baby are both doing really well, where you feel healthy and confident in taking care of the baby and the baby is doing really well, then it's reasonable to be discharged. You can stay longer. And so each day that you are on the postpartum floor, one of the midwives will be coming to talk to you and see how you're doing. And so they'll have that conversation with you about what is the best timing for discharge based on how you are doing and how the baby is doing. So the pediatricians will come to see the baby, the midwives are there to take care of you. And so it's really just an individual conversation on how you are doing, of whether or not you're kind of a candidate for an early discharge, but you can absolutely have that conversation with your midwife on postpartum.
Great. Thank you so much, Megan. The next question is for Kate. And Kate, the question is a squat or birthing bar an option for delivery? What positions can I deliver in? And what sort of things might affect my choices for delivery positions?
Sure. Thanks, Carol. Yes, the answer to that is we can definitely deliver in a squat or different positions. In general, there's a few things that might affect this. The very obvious one is whether or not you do opt for an epidural. If you opt for an epidural, there is not a restriction on what position you can deliver in. It's really more so that you need to deliver in a bed and you can't be outside of the bed when you deliver. And that is just a safety thing. You're on a monitor and you don't have full control or strength. So we need to keep you for your safety in the bed once you do opt for an epidural. Some of the positions that women with epidurals are able to deliver in, maybe on your side, sometimes using a squat bar, sometimes on hands and knees. Some of these things are affected by how numb or how heavy your legs might feel and what feels comfortable to you. With that epidural, which is a little tricky to judge until we're actually there, but for sure, as Caitlin talked about, just because you choose an epidural does not mean you'll necessarily be giving birth and laying on your back the whole time. Although sometimes that might feel right for you. If you do not have an epidural and are unmedicated, then the position you give birth in is probably going to be dictated by what feels right at that time, which is also really hard to know. But certainly we've all delivered babies on hands and knees, standing next to the bed. We don't do water birth at the hospital. You can be in the tub, but when it is time to have the baby, we do have you come out of the tub. We also have a birth stool, so it sort of puts you in a really comfortable position sometimes that we also use. So as long as everything is going well with you and your baby and we're not feeling concerned about the baby's birth or needing to have you on a monitor or closer, in the room logistically, we do really have a lot of freedom and flexibility with the position and place where you have your baby.
Great. Thank you so much, Kate. I'll answer the next question, which is, how and when do I opt into having a midwife with me? And is there a certain time frame that I need to make that decision in? So typically, as you get to know your midwife in the office, usually at some point close to the end of pregnancy, women will decide. It's most commonly, I think I've seen, after childbirth classes, after exploring what options are available for people in labor. So a lot of times, however, someone hasn't decided by the time they come in labor. And typically when you get here in labor, we'll want you to make a choice about whether or not you want a physician or a midwife so that we can properly, get you what your choice is. So there really isn't a time limit, but it's nice to be able to know ahead of labor so that you can work with the midwife and go through your birth preferences and talk about what things might work or what things might not be realistic for you. So that's the answer. If Jill could answer the next question, I'd be grateful. And that is, what are the alternatives? What are some of the things that I can use for water, for comfort in labor?
So I think Kate answered the question that at Newton Wellesley, we don't have water birth as an option. And that's quite frankly, because we don't have the infrastructure for it. The tubs need to be something that you can access from all sides for obvious reasons. And we don't have that. We do, however, have quite a few rooms with jacuzzi tubs, which are deeper than what most people have at home. And other rooms have showers. Some have a combination of the two. So hydrotherapy is what we call it officially. And I think Caitlin mentioned this early on as well, that just warm water on your body is soothing. I mean, some people don't like it, but a lot of people do. And it does not take away what labor feels like, but it does often make the contractions feel a little bit shorter and a little bit less intense. And plus, just being in water helps people relax. And that's also key to riding the waves of contractions. I would say this, I think that I can say this, Mary Kay, I think that Atrius Midwives also, we have a smaller practice, but works with the group at Mount Auburn, and they do have water birth as an option. So if that feels like something really critical to you, that you want to have that, then you should talk to your office midwives about how you can arrange to have your baby at Mount Auburn with a different group of midwives. Sometimes there's insurance issues too. So if that's something that really is something you're going to consider, I would check with your insurance to make sure Mount Auburn is covered, because you don't want to be stuck with that bill for sure.
Good point, Jill. Thank you. The next question is for Linda, and it is, are there any midwifery recommendations that might differ from a physician's? For example, delayed cord clamping. Is that something that my midwife would be open to and encouraging?
We all practice evidence-based care. And so for example, delayed cord clamping is evidence-based, that there's a benefit to that. I would say a lot of the things, if there's an issue with your pregnancy or with your labor where there may be a safety issue, I would say we're almost always in agreement. The difference in doctors is different things are at the top of their brain than are at our brain. So they will support you if you have a physician and you want delayed cord clamping. If everyone's fine, they will support you in that. It's not always, if you say, I want to deliver on my side, and we were talking about positions before, they would support you in that. It wouldn't be something that maybe they'll think of as soon as we would think of it to say, you should turn on your side. I think this baby needs to turn this way. I actually had a physician recently who said, I felt like a midwife. I never thought of it. The patient turned to her side and the baby came out so nice, but I think the patient requested it. But anyway, so it's like Jill was saying, we all have our area of expertise, and it's not that we say, oh, the midwife would always do this and the doctor would never do this or that kind of thing. It's just we have our areas of expertise and things that we're better at. If labors, sometimes Pitocin and medical interventions like that, sometimes there's an absolute, people need that. And sometimes it's, the doctor might do Pitocin and the midwife might say, I think you could get up and get in the shower, move around, or try this, you know what I mean? Or try something else, or at least have the discussion with you about where do you want to be? Would you rather just have the Pitocin or, so we differ in that way. But if you end up either for personal choice or for medical reasons having a physician, definitely talk to the physician about your preferences, and talk to, if it's a midwife, talk to us about your preferences, and we do everything we can to support those.
Great. Thanks so much, Linda. Gaitan, the next question is for you, and it's what can you do if the labor isn't progressing as quickly as we want once you're admitted? Are there certain hands-on techniques or other things that we might use to help get the labor moving along?
Well, I would say that if you haven't gotten an epidural yet, movement. Okay. I like to tell all my patients that make the room your hotel room. And just pretend like we're just walking in, like we're room service. Okay. Set the ambiance, dance with your partner. If you like reggae music, if you like country music, if you whatever you like, whatever is your style, dance in the room, and movement will help progress things along. That's like a base step. From there on, there's nipple stimulation, which helps release that natural oxytocin. We actually have a protocol, a hospital protocol for nipple stimulation because it works for some people, a lot of people actually. And so that's if you haven't gotten an epidural. If you have an epidural, then, the nurses change you and reposition you in the room, in the bed, and help to get your pelvis in an optimal position, right? So that gravity can help work and, you know, have the baby come further down in the pelvis. And then the next step after that, these are natural ways, right? And then there's the medical interventions, medications such as Pitocin that we could do. We usually start at a very, very low dose. I know when people hear Pitocin, they get very scared and worried, right, from all of the things that we hear. But at our hospital at Newton Wellesley, we start very low at 1, and we just incrementally just kind of increase it slowly. And if the baby tolerates it, we keep going up. If the baby doesn't tolerate it, we kind of stay where it's at or even turn it off. So we just kind of, it's a game, it's a dance of trying to find the right thing to progress your labor along, but also do it safely for you and the baby.
Thank you. Caitlin, if you could talk a little bit about what factors might affect whether or not somebody has intermittent or continual fetal monitoring. It's an excellent question.
Yep, sure. So what to expect when you first come in the hospital is that you will most likely in most cases be placed on the monitor in the triage side of our floor, where that is continuous. The monitor is on your belly for about 20 minutes minimum, just to make sure that we get a really good understanding of the health of your baby and maybe your contraction patterns too. And then you're moved down the hall into our labor room. And most people, if you are planning an unmedicated birth, the standard would be intermittent monitoring. And so usually what that looks like is, depending on the stage of your labor, monitoring the baby with the Doppler that you often will see that we're using in the office through a contraction and then after a contraction, just to make sure that we're not seeing any dips in the baby's heart rate and make sure that everything sounds healthy, and we can continue with that for your labor. And once things become more active and you start pushing, we do monitor the baby more frequently, but it is still considered intermittent. If you have if there is any concern during that time of intermittent monitoring that the baby's heart rate might be changing, or there might be a slight decrease, or we just aren't quite sure, we can't quite tell, then we often will put you on the continuous monitor for 20 minutes to get more information about what's going on. But if you think about this in terms of a long time of your active labor, then if everything is okay, then you can go back to intermittent monitoring. If there's any sort of medicine used such as Pitocin, or if you have an epidural, then these are more, they are considered more high risk interventions, just because the baby might show signs in the heart rate that are affected by Pitocin or an epidural. So these are certain examples where you do have to be continuously on the heart rate monitor. Or if we have concerns with your baby's heart rate after doing intermittent monitoring, then you would need to transition over to the continuous monitor. So it depends on the situation of your labor and how you're feeling and how your baby is doing. But oftentimes we do try to start with intermittent monitoring and see how your labor progresses.
And there's a couple of instances where we'll monitor you continually from the time that you come in. And one of them is if you are having a trial of labor after having a cesarean, or if your baby has meconium in the fluid, if the water's broken and we see meconium in the fluid. So those would be two more examples of continual monitoring versus intermittent. So thanks so much, Caitlin. So the next question is going to be for Mary Kay. And the question is, when I come in for prenatal appointments, do we see the same midwife team member at each appointment, or could it be a different midwife each time? And then with childbirth, does it just depend on like who's currently on the floor, and how long is a typical midwifery shift in the hospital?
Great, thanks, Carol. So it really depends upon your choice. Many of our patients, when they meet us for the first visit, they'll continue their visits with us throughout the pregnancy. If I go on vacation or I'm away, I always talk to my patients about my colleagues, Gaitan, Kate. They'll have a meet the midwife visit. So we do that within the office. Other offices, sometimes, like at Wellesley, patients might see Carol, they might see Linda, they might see Erica, they might see Megan, because they really want to choose and meet everybody. At West Roxbury, Chestnut Hill, it can be Molly or Caitlin or Gaitan. So we really, you have the option to see one or two of us. You can meet everybody within your office. It's kind of hard to go within the region, but sometimes patients want to do that too. And it really is your choice. When you come into the labor unit, we do rotate call. Some of us do one call a month, some of us do, or one call a week, some of us do 2 calls a week. So it's variable. Sometimes we'll talk to our babies in the office and say, I'm on call Saturday night, try to come in. And sometimes they listen, but sometimes they don't. But I assure you, you'll be in great hands with any of the women on this call, because when we talk about your birth intentions, your birth plans in the office, we really try to honor those when you come into the hospital. Our shifts are 12 hours. We do report in the morning and in the evening, and with the doctor and midwife teams. So everyone that's on call at the hospital knows your care plan, your birth progress, and we know all about you.
Great, thank you so much, Mary Kay. I think we have time for one more question, and then I want Sherry to talk a little bit about childbirth education and some of the things that are currently available at Newton Wellesley. So Molly, the next question for you is, how many of the midwives here are trained in spinning babies, and have we learned how to incorporate spinning babies into our care for women in the hospital?
Yeah, that's an awesome question. Thank you, Carol. So as midwives, we just know so much about the theory of optimal positioning for the passenger to fit through the passageway, which is really what centralized around spinning babies. So it all goes together in that way, and that's our bread and butter for sure. And then also there are spinning babies classes that you can take on your own. They're taught at Newton Wellesley, and we definitely recommend, as always, educating yourself for all parts of birth and labor and postpartum. So if having that information is going to be helpful to you, then absolutely go for it. I think that knowledge is definitely power in that aspect. And then also, I think I mentioned before too, that the nurses at Newton Wellesley are trained with spinning babies as well too. And they're really helpful in their knowledge base as well. So I'm all for educating and signing up for classes if it's helpful to you, but knowing that that's our bread and butter as well, is something we can also support you with as well too.
Great, thanks so much, Molly. So we have 1 minute left, and I'd like to just thank Sherry McBurney, our tech expert, and also our doula expert, our resident childbirth educator and doula expert. So Sherry, could you show us your face and talk a little bit about what might be available for childbirth for our pregnant people?
Thank you. Yes. Yay. Thank you so much. I appreciate the chance to say hi to everybody. Thank you. I've been behind the scenes and helping you with your questions. Thank you so much for asking. In my minute, I am going to tell you how passionate I am about teaching people all kinds of stuff and engaging in these conversations around just empowering you to have the most awesome experience overall, whatever that winds up being, that it's a good experience for you, that you feel heard and listened to, and you're in the right place if you're here working with these amazing midwives for sure. And so there's so much more information. Some of you guys asked really good questions like that we would cover in childbirth class or the virtual tour. So I'm going to put those links right into the chat so that you guys are able to enroll in any of those things. Come take a class with us. The tours are free. They happen all the time. And I'm delighted to engage in any other types of conversation, especially if anyone is wondering about doula support, what doulas do, how we work with these amazing folks up here. I'm just so grateful for the chance to support you here and elsewhere. So thanks a lot, you guys. I appreciate it.
Thank you so much, Sherry. So the last thing I want to tell you all before we sign off is that if you have a question either now that we didn't get to or when we end the webinar and questions come up for you, please, please, please ask your midwife in the office. If you haven't seen a midwife, or if you or haven't seen a midwife recently, make an appointment, get your questions answered. Our job is to give you the information that you need to make the choice that's best for you, and then to support you in whatever that choice is. So, so definitely take us up on that. You can email us or you can see us in person. I hope you guys all enjoyed and got some information from the webinar. And please, again, reach out if you have other questions. We'd love to answer them for you. We hope to see you in labor. Everybody have a good night.
Good job, folks.
Great job. Great job. Let me, I'm going to stop. There we go.